And welcome to the Dr. Bob Show. I heard an interesting fact on television the other day. It said that most strokes can be avoided. That's an interesting fact. Can strokes be prevented and avoided? We'll be spending most of this show talking about that. What can we do to prevent and avoid having a stroke? My guest is Dr. Malcolm Foster. He'll be teaching us that information. Some of the information you'll know. Some of the information is brand new, and you're going to be very excited to understand various causes of stroke. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about cellulitis, how dangerous can it be, and how to recognize it, and hip replacement. Is it as difficult as knee replacement? And are there different types? You're going to be pleased with the answer. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Malcolm Foster, board-certified cardiologist, and we're talking about stroke prevention and avoidance. Can we really do that? Malcolm, welcome to the Dr. Bob Show.
Thank you, Dr. Bob.
When we think of strokes, I read an article the other day that said most strokes can be prevented. Do you feel that may be the right fact?
Yes. Most strokes can be prevented.
So how are they prevented? What do we have to do to prevent strokes? Because nobody wants to have a stroke. Do people die of strokes, or it's the residual left over that they're afraid of?
Well, people do die of strokes, but it really is the #1 cause of disability among medical illnesses.
Same article I read, $34 billion with people that are recovering from strokes. So how can we prevent them? What are some of the things we can do?
I think for starters is to look at the risk factors for stroke and address the risk factors and modify the things that we can.
So risk factors, name me 3 or 4, and then we'll talk about them individually.
Sure. So some of the important ones are high blood pressure, high cholesterol, diabetes, and smoking.
So let's go to high blood pressure. What is a normal blood pressure? I am shocked that people don't know what their blood pressure is. What's normal?
Well, normal or ideal blood pressure is actually less than 120/80.
So 120/80 is the golden standard. What level do you have to get to be in danger of a stroke? Is there any number?
Not a particular number, but if the blood pressure is consistently more than 140 millimeters of mercury, for example, then that would be high blood pressure, would typically be treated with medication.
So what does that high blood pressure do to the blood vessels that would cause a stroke? What would it do?
It really causes long-term damage to the surface of the blood vessel called the endothelium.
And that damage can lead to blockage. 2 kinds of stroke. What are the 2 kinds of strokes?
There are ischemic strokes, which is lack of blood flow to the brain, and then hemorrhagic strokes, which is a bleeding stroke in the brain.
Can high blood pressure cause both of those?
Actually, it can. It's a risk factor for both ischemic strokes and hemorrhagic strokes.
So you mentioned another risk factor, high cholesterol.
Yes.
Tell me about cholesterol, what we can do about it to help our cholesterol levels to avoid or prevent strokes.
All right, so cholesterol is one of the major risk factors for plaque buildup, and plaque buildup can cause blockage in the carotid arteries leading to the brain or the blood vessels within the brain.
So if the hardening of the arteries gets too bad, you can have an ischemic stroke or a hemorrhagic.
Mostly an ischemic stroke, so high cholesterol goes along with plaque buildup and ischemic strokes.
So it blocks the artery. The brain, does it need a lot of oxygen?
It does.
You know, it needs more oxygen than any other organ. So if you take that oxygen away, you've got some problems.
That's right.
So what cholesterol levels are we looking for, and how do we get good cholesterol?
So we like to see total cholesterol ideally less than 150. And the good and the bad cholesterol, the LDL is the bad cholesterol. We like to see it low, under 100 or even under 70. And the HDL, the good cholesterol, we like to get that up.
So if people know their values and they don't meet those values, what can we do to lower our cholesterol?
So improve the diet, improve exercise, lose weight, but many people need cholesterol medication, and we have very effective medications like statin drugs that lower cholesterol.
When we use statin drugs, do you have to build up the dose? Do people have muscle cramps, muscle aches, problems that say, I can't tolerate this?
They can. Most people can take statins and they do not have any side effects, most people. But there are a percentage of people that get muscle aches in particular and they cannot tolerate statins, and we have to look at some alternatives.
So now we've got high blood pressure, we've got cholesterol, we've got both those under control. How about diabetes? How common is that? And how does it cause problems that can cause stroke?
Well, it has become more and more common. We really have an epidemic of diabetes in our part of the country and in the United States. So more than a third of people now are developing diabetes in the population. And it relates to plaque buildup. It relates to stroke within the brain as well as plaque buildup in the carotid arteries.
So I can remember one time a guest saying, if you have an elevated blood sugar, if you have the diagnosis of diabetes, it's a wake-up call for your heart, because it's time to get really serious about your cholesterol, about your blood pressure, and about your diabetes. So what do you do about the diabetes, especially if it's type 2?
So you're right. So we call it a heart disease equivalent, and it's very important to change lifestyle, to eat better, get the weight down, especially with type 2 diabetes, which in adults, and also to control the blood sugar.
Smoking?
Smoking is a powerful risk factor for stroke and can be modified by quitting smoking.
People have a difficult time stopping smoking. What do you tell them? If somebody's smoking, you know the dangers, you know what's in store for that patient. How do you get them to stop smoking?
Well, I always encourage them. I never quit trying, and I tell them to never quit trying. And we talk about a variety of strategies and techniques to quit smoking, but we just have to keep after it.
And I think that's so important. It's not just one time stop your smoking, it's over and over
That's right.
and over. And there's lots of things that people can do to stop that. So how about being overweight, obesity, sedentary lifestyle? What does that mean, sedentary lifestyle?
That means not exercising. So being a couch potato, we'd like to see people exercising almost every day. You know, ideally 6 days a week. You get 1 day of rest, but otherwise keep exercising.
So we've gone through risk factors. If we follow those, if we keep our blood pressure good, if we keep our cholesterol where it should be, if we stop smoking, if we get our diabetes under control and get more active, think it really cuts down on the incidence of strokes?
It does, considerably.
And so it's time, that's a wake-up call. How about other factors? Because what we've talked about is routine for risk for both strokes and for heart attacks.
Right.
So I want to talk about PFO and atrial fib. Can those cause strokes?
Yes, they can.
And that's what we're going to be talking about when we come back. What's a PFO? It's something really that we've known for a long time, but we're learning now that it may be a major cause of stroke. So we're going to find out what we can do about that and how we can take care of it. And atrial fib, how does it cause a heart rhythm problem? How does it cause strokes? You'll want to stay tuned for this second part. We're talking with Dr. Malcolm Foster, board-certified cardiologist, and we've been talking about, yes, you can prevent strokes. You have to know what the risk factors are, and you have to handle each one. So if you've got high blood pressure, you've got to get that under control. If you've got diabetes, you've got to be active and get your blood sugar under control. If you've got an elevated cholesterol, you need to exercise or take statin or appropriate medicines to get that under control. If you're smoking, you must stop smoking. More people smoke in the southeastern part of the United States than any other part of the United States. So stop smoking. It will improve your health. And then we've got to get active, and we've got to be sure that we don't get too overweight. Is that pretty much a summary of risk factors?
Yes, perfect.
So let's talk about some of the heart problems. Specifically, the one I'm thinking of is atrial fibrillation. Now, what does atrial fibrillation mean?
That's where the upper chambers of the heart go out of rhythm. So normally the upper chambers and the lower chambers are coordinated, but the upper chamber goes out of rhythm entirely. It just fibrillates like a bag of worms.
So it's not effectively beating, it's just wiggling sort of thing.
Correct.
When that happens, will that cause a stroke?
Well, blood clots can form in the atria when you have atrial fibrillation. And blood clot can then get out of the heart, be ejected from the heart, and throw a clot to the brain.
Wow. So a common cause of stroke?
Fairly common, up to 20-25% of ischemic strokes.
So if people feel a fluttering of their heart, or it flutters, could that be an indication that it could be the beginning, or they could really have atrial fibrillation and not really know it?
It's a possibility. Oftentimes, just irregular heartbeats, the rhythm is normal, but a person has extra heartbeats. However, we want to be alert to atrial fibrillation where it is irregular all the time.
So if it's irregular all the time and you get a blood clot and you could throw it to the brain, how do you know whether they're having it half the time or not? What can you do? Do they usually have it for a minute, or do they usually have it for 12 hours?
Well, the natural history of atrial fibrillation is that it is an occasional event that becomes more common and more common until they're in atrial fibrillation all the time. So it really requires some monitoring and a visit with a physician, usually a cardiologist or a primary care physician, to monitor the heart.
So how do you monitor atrial fibrillation? What do you do? Do you try and slow the rate, or you try and get rid of it with medicines? What do you do?
Well, we do both of those. Very importantly for stroke prevention is using a blood thinner. So we look at people that have a risk for blood clot and stroke due to their atrial fibrillation, and we put them on a type of blood thinner to prevent clots.
Now, my father was a physician, and he used to have lots of people on Coumadin, and they had to come in for blood tests all the time. There are other blood thinners now. What are some of those?
Right, so we have some newer blood thinners. We have medicines like Pradaxa, Xarelto, Eliquis.
Are they good?
They're excellent, yes.
And so they can keep that blood clot from forming, and you don't have to have blood tests?
Correct. So they actually work better than Coumadin, and they are safer than Coumadin. Each of those drugs was tested against Coumadin. So they're really, we have wonderful new therapies for patients.
So if somebody's got atrial fibrillation, and they're on a blood thinner, can you stop the atrial fibrillation? Can you do things to stop it? What do you do?
So there is a procedure called ablation. Well, first of all, we can do cardioversion. That's an electric shock.
I see that on television,
Right.
where they put the
paddles.
on, boom,
And
that's really what happens.
Yes, it does. We give an electric shock. And in patients in whom the atrial fibrillation comes and goes, we do an electric shock that can put them back into rhythm. There's also a procedure called ablation that can be used to treat the atrial fibrillation and get patients back into normal rhythm.
What is ablation basically? How do they get rid of the atrial fibrillation?
It's electrical short-circuiting of wires within the heart so that the normal pacemaker cells can take over.
Effective?
It's very effective, yes.
So we've got things that we can do to get the atrial fibrillation to go away. What if it doesn't go away? We've got medicines that help prevent the clots from occurring other than blood thinners to improve the rate. What else do we do?
Right. The other thing is there's a fairly new procedure called the Watchman device, and that's a left atrial appendage occluder. So it's a plug that specifically goes into the appendage that hangs off the left atrium, and that's a common source of clot. So if you put a plug in there, then there's no opportunity for the clot to form.
Now that left atrial appendage, I used to sort of think about that as a dog's ear up in the left atrium. And so you can put a plug where blood can't get in there, so you don't get a blood clot, so you doesn't throw the brain, so you don't get stroke.
That's correct.
So tremendous things that you can do about atrial fibrillation so that you don't get stroke. Can you cheat on your blood thinner?
Well, we encourage people to be very consistent about taking their blood thinner.
Yeah, and I think that's a terribly important thing.
Yeah.
So we mentioned one other thing, a PFO. What's a PFO? This is sort of new to me.
So PFO is something that you and I and everybody else had before we're born. It's a way that the blood flow can communicate throughout the heart in the baby before the baby's born. If you look at the population, it's still there in about 1 out of 4 people. Typically, you do not need to do anything about that, but if a person has had a TIA, or warning sign of a stroke, where a blood clot has gone across that defect, that is a person that may need to have the PFO treated.
So a TIA, transient ischemic attack,
Yes.
where they may have some symptoms of a stroke, but it goes away quickly.
Right.
That could be from a PFO, patent.
Foramen ovale, and that is a little hole or a flap in the heart that, again, we all have from birth. If a person has an unexpected or unexplained stroke, particularly in a younger patient, it may be a PFO.
So what can you do about a PFO? How do you make the diagnosis, and what can you do for it? I think this is the exciting part.
It's very exciting. So we can make the diagnosis with ultrasound, called an echo, and a bubble test, called a bubble study. And if we can see bubbles going across the defect, that tells us that clot can go across the defect as well. If that's the case, it needs to be repaired, and it can either be repaired with a plug or it can be repaired with surgery.
Well, what does a plug look like?
Well, I have one for you.
Good. I saw that on the table. I said, I wonder if that's the plug.
This is the plug. So the plug is like a door stop. It's like a door stop. So it is one side of the plug is on the right side of the heart, the other side of the plug is on the left side of the heart, and it goes across the defect.
So it goes across the defect, keeps blood from going through the patent foramen ovale.
Yes.
And so therefore you're not going to get any clots that go to the brain.
Exactly.
Pretty stable when you put this in. Does it stay in? Does it want to come out? Are there any problems with blood clots around this?
Good questions. No, it's very stable and it heals into place. It gets a lining or a covering as it heals into place, and it's very stable. And after that is implanted, patients go on and do normal activities, up to and including have gone back and played in the NFL.
Oh my goodness. So you have to have a high index of suspicion if somebody has some intermittent symptoms to look for the PFO.
That's right.
You do a bubble test and an echo.
That's it.
A bubble test, that's the first time I've heard of that, which I think is really, really great. It's got to be done by a cardiologist or somebody that really knows how to correct that. Malcolm, you've taught us that we can keep strokes from occurring. You've taught us how to prevent strokes from a heart standpoint. How about the carotid artery? That has a lot of blood that goes to the brain. Can we fix that if it's blocking blood to the brain?
Yes, the carotid artery can be treated either with surgery or a stent.
So lots and lots of things that we can do to prevent strokes. So people, if they listen and if they get their risk factors under control and they know cardiovascular, they're okay, they have a great chance of not having a stroke.
Exactly.
You're a wonderful teacher. I'm always just amazed at how fluent you are in educating everybody and how advanced you are in technology and improving health for us that could potentially have a stroke.
Thank you very much.
Know that you can prevent stroke. So get those risk factors under control. Be sure that if you've got atrial fibrillation that's under control. And if you've had TIAs, think about PFOs. A lot of little words, but they're so important to you and your health. Now we're going to want to stay tuned because we're going to be talking about cellulitis. What is it and can it be dangerous? And hip replacements. There's an anterior and posterior approach. Why are they different? And is it better or easier than knee replacements? You'll like the answers. Hello, I'm Dr. Bob Overholt, here to encourage you and your family to get out and play in our Knoxville area parks. Knoxville has dozens of parks and more than 85 miles of trails. There are picnic shelters, ball fields, tennis courts, and disc golf courses, dog parks, fishing ponds, and skateboard parks, trails for hiking and mountain biking, boat rentals, you name it, Knoxville has it. To find a park or greenway near you, visit OutdoorKnoxville.com and get out and play. It's good for your health. I want to thank Dr. Malcolm Foster. Excellent discussion on preventing and avoiding strokes. Know your risk factors, take care of your heart problems. And now from questions from you, the viewer, that I think will be important to your health. Dr. Bob, what is cellulitis? Well, cellulitis is a skin infection. It's usually on the lower extremity. It's usually red, hot, and tender cellulitis. There's some 200,000 cases reported every year. It's really very, very common. Somebody skins their knee. Mother Nature comes in and tries to bring in blood vessels. That makes it red, gives it a little warmth, gives it a little bit of swelling. But if it gets hot and you get a low-grade temperature and it becomes very, very tender to touch, then you may be running into trouble. You must see a doctor quickly, and an antibiotic will usually take care of that. Now, there's two types of bacteria that predominantly cause cellulitis. One would be called Streptococcus pyogenes. That's a strep infection that produces pus. Now remember, the skin on the outside protects us from rain and drops. It's when we cut that skin, the cellulitis is deeper than that. The other bacteria is Staphylococcus aureus, and sometimes we get a methicillin-resistant Staph aureus. So that's the MRSA that we talk about. Those can be very, very serious infections. If your cellulitis does not respond to treatment, then you need, the thing that we worry about is a necrotizing fasciitis. That's what we call the flesh-eating bacteria. And that's the same bacteria. It's just it gets deeper down where the fascia is, it spreads more easily, and it can be certainly life-threatening. You have to be hospitalized for that. There are medications that we can take for that. We can get cultures and sensitivities. So know that if you have cellulitis, most of the time it's easily treated, but if it's not responding, then you need to go to the emergency room quickly. And now, second question. Dr. Bob, tell me about hip replacements. Are they more difficult than knee replacements? It's a good question. In general, hip replacements respond much better than knee replacements, so they're easier. But let's look at that a little bit more carefully. If you've got a bad hip joint, if you've got arthritis in the hip, if you've got damage to the hip from a congenital abnormality or from an automobile accident, don't think you're going to have a hip replacement and jump right up and bounce around. You've got to prepare for it. You got to get the house ready, so after you've had the surgery, the hip joint replacement, it's a ball and socket joint. You need to be sure that you're able to get through your house without stumbling and having obstacles. You need to be sure that you follow your doctor's instructions after the surgery. Usually people are doing pretty good in 6 to 8 weeks after a hip replacement. It can take longer. Every hip is different. Every patient is different. There are two approaches that people have. There's an anterior and a posterior approach for hip replacement. The advantage of the anterior is that the hip doesn't pop out if we cross our legs. After we've had a posterior replacement, we have to be careful how we sit. If we sit where our leg goes out to the outside, the hip joint can pop out. So talk that over with your doctor. The anterior approach usually can be done with minimal invasive techniques, whereas the posterior may give you a little bit better view of the joint, but has greater chance of having problems. Follow your doctor's instructions. Know that they do a great job with hip replacement, so look forward to being able to walk again. It's all the time that we have for this show. Remember, you need to be exercising. You need to exercise 20, 30, 40 minutes, 6, 7 days a week. If you do that, it will lower your blood pressure, it will lower stress, you'll feel better, you'll perform better, and you'll be healthier. So know that exercise is so important to your health. Sleeping 7.5 hours? So how are you going to do that? Well, number one, we have to know how to sleep. We need to be sure that the bedroom is nice and quiet and dark, and if we've got pains or if we've got medicines that are keep us from sleeping, we need to acknowledge that. Get yourself ready for a nice, restful night. When you go to bed, know that there's going to be 7.5 hours before you have to wake up. So get in a routine. Go to bed at the same time. Wake up at the same time. If there's too much noise in the house, you can use sound machines. Be sure that the covers are comfortable. Be sure that that bed is just someplace you want to take a nice 7.5 hours sleep. And then eating properly. You know, we always have a diet that's on our mind. Well, eating properly is such an important thing for you and me to do. We've got to start the day off with fruit and fiber. So you can have a type of fruit, fresh fruit. You can have cereal that has fiber. It's the volume that you eat, so don't eat a lot. There's no problem eating eggs for breakfast. So you can have an egg, you can have whole wheat bread, you could have cereal, you can have a good breakfast. And then an hour or two later, have a snack, half an apple, half of a banana, and know with that snack, it'll keep your body from getting hungry. At lunchtime, look how much you're eating and make it a very, very small portion. Snack in the mid-afternoon. Eat a small supper, and then don't eat before you go to bed. And most of all, what is it we like? Spend a lot of time laughing. Find that person, laugh a lot, giggle a lot, and you'll stay healthy.